Now, spiralling medical costs have been a concern for years to South Africans, to government as well. Now, the Council for Medical Schemes is looking at the impact of fraud, waste and abuse in a summit tomorrow and Friday. It says fraud and abuse cost the healthcare industry over 22 billion rand per year. The scheme's focus is on private healthcare where many patients are on medical aid. So what that means is higher premiums for everyone because of the abuse. To discuss, we're joined by the CEO for the Council of Medical Schemes, for medical schemes, Dr. Sipho Kabane. Thank you for being with us, Doctor.
Thank you very much.
What is the worst abuse case that you've heard of? Give us an example.
Well, we've got abuse basically that is perpetrated from the service provider side, where, for instance, patients get admitted to hospital for a procedure that takes only a few minutes, but then, the claim is for the whole day. And you also have patients that come to hospital for a minor ailment, and a battery of tests that are quite expensive are actually, administered on the patient. And
so basically
you also
doctors are going above and beyond the call of duty, adding these extra services where they can.
Certainly.
If I'm on a medical aid scheme, what sort of premium, how much extra am I paying because of this sorts of things?
Well, currently we've got the annual contribution increases. They differ from scheme to scheme, based on the risks faced by that pool of members. But we do have schemes that are charging contribution increases that are far in excess of the CPI, some up to 3% plus.
But what sort of portion am I paying towards abuse, if that makes sense?
Well, currently we estimate that out of the 160 billion claims that are paid annually, about 15% of those are associated with fraud, waste and abuse.
So our medical aid costs could come down by about 15% if this is rooted out?
Theoretically, yes.
Tomorrow's summit is a gathering of medical schemes themselves. Your members, they sort of make up this money from contributions anyway. Why should we believe you want to bring things down?
Yeah, just correction. We regulate schemes, Schemes don't actually belong to the Council for Medical Schemes.
Thank you.
And the people that we're bringing tomorrow is not just the medical schemes, but the administrators. We've got patient representative groups. We've got groups from the service provider side. We also have stakeholders from state security agents, your special investigations units, as well as forensic scientists. Because all of us are trying to put our efforts together to ensure that we put proper systems in place to prevent and combat fraud, waste and abuse.
Do medical schemes play any role in this themselves?
Well, medical schemes essentially are not-for-profit organizations, and in many instances they outsource.
Discovery Health is a not-for-profit organization?
Discovery Medical Scheme is not, but there's Discovery Pty Ltd, which is the administrative arm. Those are the people that are for profit here. So in a sense, you also do have schemes that do self-administration. So they are involved, either directly or indirectly through the agents that they appoint as administrators.
I've heard a claim, and I'd like to put it to you. Tell me what you think. One of the problems is a lack of competition, and the Competition Commission itself has found that there's only 3 major hospital groups in this country. We need more. I've heard, though, that the big medical schemes can work with those hospitals, can push them down, but they have the volumes to make those big medical schemes happy. Does that contribute at all?
Well, I think the strategic purchasing power of the large medical schemes and their ability to negotiate and bring costs down should theoretically be passed on to members and result in lesser annual contribution increases. But we don't see that carry-through effect in many of these negotiations, and that's a cause for concern.
So the medical schemes retaining that profit, as it were?
Yes.
And we're not seeing enough competition in the healthcare industry itself.
Well, currently, I mean, we've got a few administrators. The number of schemes themselves are decreasing. A few years ago, there were 85 or so of them. Now we're sitting on 79. And in part, it's because the pool where they are drawing members from is not increasing. It's been stagnant at 8.8 million for the past 4 or 5 years. And one of the reasons why that pool is not growing, it's the increasing annual contribution costs, which means people find it unaffordable and they leave schemes or drop dependence, and those that want to join find it unaffordable.
So medical schemes themselves, what I'm hearing, have to take this very seriously because costs can't keep going up. They need members, in fact, in future.
That's correct, yeah. I mean, medical schemes, like many insurances, survive by having large risk pools where you get cross-subsidization between the sick and the healthy, the young and the old, and the rich and the poor. That's how they survive. Now, if you've got a smaller risk pool, then it becomes unsustainable. So there's a sustainability issue for medical schemes.
If we go back to the fraud, the abuse, what sort of percentage of hospitals and doctors are dubious, are overcharging us?
Well, we don't have the exact number here because even the estimates that we have are based on those cases where, firstly, there's been a suspicion and a determination that this was a fraudulent activity. A lot of the claims actually do get paid without any determination being made whether they are fraudulent or not. So we suspect that the estimates that we have may be a tip of the iceberg.
And how can that change? So you're talking about a lack of fair sanctions for convicted fraudsters. What's happening right now if you're a doctor who's found guilty?
You see, the problem right now
You're saying they're not even being found guilty in the first place, I guess.
Well, the problem is we've got different regulators regulating different players in the industry. For instance, we regulate the schemes, the administrators, managed care organizations and brokers, but you've got the Health Professions Council of South Africa regulating the professionals. You also have the state, law enforcement agencies that look at the criminal side. But for the first time, we're bringing all these regulators, together to make sure that, nothing falls through the cracks. Currently, if you were to go to a local police station and report fraud of medical aid, the law enforcement officers are not even aware of the existence of the Medical Schemes Act and its regulation, and let alone how to interpret that. So part of the efforts that are going to come through this Fraud, Waste and Abuse Summit is the cross-pollination of ideas and the training of law enforcement officers to understand how to deal with cases of fraud, waste and abuse in the medical schemes arena.
Would you need a specialized unit, something in the prosecutions authority, something like that?
We are working with a special investigations unit already, and I suspect that yes, when we train, would need to start by making sure that there's a critical mass of well-trained officers where if there's fraud, waste and abuse, you can actually report to them, and then they can ensure that that is carried through and there's a case and people are found guilty and the requisite punishment is given.
What can ordinary people do? Ordinary members of medical schemes, if they think that the system is working against us all, if they notice abuse?
Well, because members are basically the ones that are the ultimate victims of this fraud, waste and abuse, because they have to pay more to remain in the scheme. I think if they detect any fraudulent and waste and abusive practices, they should be reporting these to the correct authorities, but they themselves must abstain from colluding with service providers in fraudulent activities.
So members themselves are contributing?
Yes.
How?
There is collusion sometimes between a member. I mean, we've heard of practices where, for instance, a member of a scheme would, give a card to a relative who's not a member of the scheme. And this person, with the collusion of the service provider, get serviced as if they are a member. And that in itself is a fraudulent claim.
And kickbacks are paid.
We've heard of people buying groceries using medical aid funds, cards, and sometimes exchanging these for cash. So members of scheme are by no means, the innocent party here, even though they are the ultimate victim.
Are legal cases part of this? Just an opinion, because this is important. People need to be protected from unscrupulous doctors. But I've heard from gynaes that the cost of insurance against legal claims is making many people turn away from that speciality.
Well, that's a different kind of a discussion altogether here, because it talks to medical legal claims, which in effect are based on adverse events that happen.
Which shouldn't happen in the first place.
Well, I believe that to err is human. Even in the best circumstances, you will find mistakes happening. But I believe that a lot has to be done to bring those down here.
There's been a fear among some healthcare providers, even medical schemes, about the impact of the national health insurance. Government showing a commitment to that again. Is this necessary, this introspection by the industry itself, to prevent government stepping in more harshly in future?
Until the dispensation of the national health insurance is in place, the status quo will prevail. And I think it's the responsibility of all the stakeholders here to ensure that none of the resources that are aimed at providing essential healthcare services actually leak out of the system and go to the people that are corrupt and are fraudulent. And I believe that if we create sufficient policies, operating procedures and charters, this would be equally applicable, even in an NHI environment.
All right. Well, ahead of that summit, hopefully we will see concrete proposals to bring the cost of healthcare down. That was the CEO for the Council of Medical Schemes, Dr. Sipho Kabane.